So, hi, Dr. Ko. I'm Julie, as you know, and I'm working on the COVID vaccine confidence grant, as well as Michelle, Layla, and Lucia, who are also on this call. We're all working on the grant. So, first, I'll just introduce Dr. Ko. So, Dr. Ko is a professor of internal medicine and pediatrics at the David Geffen School of Medicine at UCLA and of health policy and management in the Fielding UCLA School of Public Health. She's also chief of medicine pediatrics at UCLA. Her research interests include access to and delivery of developmental services, cognitive and language development in young minority children, and services for children and adults with autism and other neurodevelopmental disabilities. So we're going to talk with you today about the needle anxiety program at UCLA, and we're interested in learning about the program generally and what you have learned about needle anxiety in the neurodivergent and disability community during the COVID-19 pandemic. That's kind of what we're going to want to touch on today during this interview.
Sure, no problem.
Okay, so I'll just go ahead and jump into the questions. So the first question that we have is, how do you explain needle anxiety to your patients and their family members?
Well, so I take care of both patients with disabilities and without, and I think needle anxiety cuts across all populations. In the general population, it is up to 10% of patients who have needle anxiety of some form or fashion, which actually would lead to some change in health behavior. So having an anxiety about needles or procedures to the point where you avoid or delay scheduling a follow-up appointment or a particular procedure or things like that. So studies have shown that that's up to 10% of the population. And I have not yet seen this studied in disabled population, but I suspect that it's higher. 10% in the general population is already significant. And so I think having a solution, a way or a strategy to approach decreasing the anxiety around a procedure that involves needles would help everyone with this concern and not just disabled populations.
Great, thank you. And the next question is, why is it important to discuss needle anxiety with your patients with respect to COVID-19?
Well, I think that because COVID-19 is a new vaccine, there are lots of concerns and hesitancies and anxiety surrounding that particular vaccine in the first place. And so, as we're seeing across the country trying to immunize as many people, eligible patients against COVID-19, we are seeing efforts stall due to some of these hesitancies and concerns and anxieties. So if needle anxiety is contributing to people not getting the COVID-19 vaccine, I think we definitely want to address that one, because that is perhaps a little bit easier than some of the other concerns that people might have around this new vaccine.
Okay. And are there specific groups of people who tend to have needle anxiety? And if so, what are the main reasons that they usually give for why they have needle anxiety?
I don't know that they know exactly which people will tend to have needle anxiety, but in my clinical experience, I do think that it is patients who tend to be anxious in the first place. So a number of my patients are being treated for anxiety, and it's not surprising that some of them, have a specific phobia or fear of needles. But I will say that I have patients also who have no history of anxiety, who just have a single sort of fear of needles. So I'm not sure that they know exactly who is at risk for having needle anxiety, but as I mentioned, it's pretty common. I see it in particular in association with the 11-year-old vaccine for all children. So they're at the 11-year-old well child visit, there are a couple of booster shots and vaccines that have to be introduced. And that's where all of a sudden you'll see both boys and girls with needle anxiety that comes, that becomes more evident. And I think in this age group, in this age group in particular, we don't want to restrain the child as we may have when they were 4 years old. And what's interesting is that I have parents who are surprised when they find out that their 11-year-old has needle phobia, because they don't remember that in the 0 to 4 age group that there were problems with giving vaccines at that time.
Okay. And how would you describe needle anxiety within the disability community and neurodivergent community?
Yeah, so I think in this population it's a little bit different because we know that individuals with neurodevelopmental disabilities may have sensory concerns. And so because a vaccination involves a needle that does puncture the skin, and on top of the anxiety, if there are sensory issues, this population may have sort of increased challenges with receiving a vaccination or getting blood drawn.
Okay, thank you. And now I'm just going to ask more specific questions to the needle anxiety program. So can you just give us a general overview of what the program is?
Yeah, so about 3 years ago now, I have been caring for a predominantly disabled population of patients in my practice, and getting routine blood work or giving vaccinations was becoming more and more of an issue. And I went around and I tried to explore places that my patients could get these procedures done, that would not be compromising their regular health care. So I think, again, it all comes down to the fear of needles to the point where they're not getting the care they're supposed to be getting. And that to me leads to a service disparity. So if we look at vaccination rates for disabled children, they're likely to be lower than the general population, and needle anxiety could be contributing to that. So that's a disparity that I wanted to address. Um, and similarly, like getting blood drawn in overweight disabled patients with diabetes, in the general population, we typically do this every 3 months. But in talking to other primary care providers, if patients have needle phobia or are not easy to get blood from, the provider is okay with not getting the blood drawn every 3 months. And so that's a deviation from standard of care that I'm not that comfortable with. And so I reached out to the emergency department, who, routinely gets blood from disabled patients, and they have a number of methods of doing that. And asked if we had these types of patients, would they be able to go to the emergency department just to get their blood drawn? And the emergency department said, no, don't send them to us because they will have to wait and be, in the priority. And something like this would be very low priority, so they would likely have to wait a long time, which is not great for a disabled patient or a neurodevelopmental patient who, who might be overly stimulated or overwhelmed with a lot of noise and having to wait. So then I went to the outpatient surgery centers, and I talked to the anesthesiologist, and I said, well, would it be possible to have them do it with an anesthesiologist because they're so skilled and they could do a little light sedation? And then the answer there was, well, if we did that, the patient family or the patient would be charged for the OR time in the same day surgery center. And then insurance wouldn't necessarily cover it, which would mean that the patient would be stuck with a bill for several $1,000s, just to get the blood drawn or a vaccine administered. So that didn't seem like a very viable option either. And so basically it came down to our evaluation and treatment centers, which are sort of more advanced urgent care centers with an RN staffing and the ability to give IV fluids and IV medication. And so we started exploring the possibility of doing these procedures at UCLA. We have 3 of them, and they have extended hours, which is nice because they're open 8 a.m. to 9 p.m. on the weekdays, and 9 a.m. to 5 p.m. on every weekend and holiday. So they're open 365 days a year, which is great access. And then going through the protocol took us probably 2.5 years to get it approved by all the different entities at UCLA that would need to approve our administration of an inhaled benzodiazepine in the urgent care site.
What would you say is the main purpose of the program?
Well, the main purpose is to be able to provide strategies for patients with needle anxiety or trypanophobia, which I think is an official DSM-5 term, to be able to receive basic vaccinations and blood draws for lab tests. And so, you know, most patients routinely receive these interventions in the routine care, in the routine care that they receive in the primary care office. And so maybe 90% of the patients have, little to no difficulty receiving these procedures. But for the 10% that experience difficulty, by being in the needle anxiety program, we can, for example, provide numbing cream like EMLA, a topical local anesthetic that could help numb the skin. We also have devices called the Buzz EV, which is a device invented by a pediatrician, which you put in the freezer, and so it's cold, but it vibrates, and you place that on the skin of the patient near where you're going to be giving the injection or drawing the blood, and it keeps it numb. And if none of those strategies work, then we resort to a light sedative, which is delivered through the nose via a nose spray. So it's called inhaled midazolam or Versed. And when we have to do this, what's nice about midazolam is that it's very short acting. And so once you are able to spray it in the patient's nose, within 10 to 15 minutes, they are lightly sedated. They completely breathe on their own, and they even respond to questions, but they're just not as anxious, and we're able to do the procedure. And then the anesthetic wears off in about 15 minutes. So it's sort of ideal for this type of situation. They're in the clinic, so they're completely monitored. And it gives the patient the dignity and the ability to undergo these procedures without a severe anxiety reaction.
And are these interventions for just any patient with needle anxiety, or is it for specific different communities of people?
It's for anybody with needle anxiety over the age of 7. So we have had non-disabled patients be in the needle anxiety program as well. In fact, our very first patient was a 30-year-old female with no disabilities who just has always had needle phobia. And then even this past clinic on Friday, I had a 16-year-old that needs blood work drawn, and she does have ADHD, but no sensory issues and no other neurodevelopmental conditions. And as soon as I mentioned the blood draw, she just broke down in tears in the clinic, and so was adamant that she would not be able to give blood without some sort of intervention. And that's when I explained to her about the needle anxiety program, which she will use later this summer to get her blood test.
Okay, great. And for the different patients that you have used these interventions on, were there overall successes? Can you explain a little bit about that and the successes of the program?
Yeah, so I would say we've done it on maybe about 20 patients since we started the program last August. And Kendall will give you a better idea of the successes. My understanding, and having witnessed a couple of them, is that it works well when the parents are, or the family member who brings in the patient is also supportive and calm and understands exactly what's going to happen and is well coordinated. We do our best to reduce the anxiety in other ways without necessarily using the inhaled midazolam if necessary. So sometimes parents are comfortable giving a small oral sedative before they come. And the parent is convinced that we're going to need the inhaled midazolam, but because it's in such a controlled environment and our staff are so amazing, that the mild oral sedative that they take an hour before they come to our clinic is often enough. And then we don't actually even end up giving the inhaled midazolam. I think what's really nice and maybe even just symbolic of the needle anxiety program is that we restored the dignity back to the patient, and that the parents are amazed that the experience can be different from what they've had in the past, because we've had patients drive as far as 2 hours to come to get this, to participate in this program. And for their adult child who is, 6'4" and 200 something pounds, and the thought of getting enough adults to hold that individual down to be able to draw blood or administer a vaccine is really undignified. And they're just really amazed that this can be done in such a calm setting. And I think this restores that patient dignity.
That's great. And if any patient comes in that is under 7, is there somewhere you can refer them to, or what happens for those patients who have needle anxiety, but they're under 7?
Well, so I think the challenge is that for children under 7, we understand that developmentally, many children don't like to get shots or needles or have their blood drawn. In general, again, those children are a little bit smaller. And so, restraining or talking them through or having them sit in their mom's lap or a parent's lap is often enough for us to be able to do the procedure. It's not that the inhaled midazolam comes without any risk, but I think when we talk about the risk benefits, it's greater in a child over the age of 7. And under the age of 7, I would say we'd have to evaluate on a case by case basis. But honestly, I think the practice in pediatrics for younger children is to restrain by the parent in a loving way, through a hug, a bear hug, or something like that.
Okay, thank you. And how can patients learn more about UCLA's needle anxiety program or access similar services?
Well, we're developing all those materials now. So we hope to be able to share resources to other institutions interested in implementing a similar program at their institutions in their health system. And then here at UCLA, we also are planning to let other primary care providers know of this service. I think sort of providers who take care of many disabled patients already know because we get those referrals. But we haven't yet advertised widely until we develop those materials this summer.
Okay, and as you're developing those materials, are there any recommendations you would provide to other providers to assist with their own patients who have needle anxiety, like outside of this program?
Yeah, I think one thing that we have tried to do through ambulatory nursing is to train all the medical assistants to acknowledge patients' anxieties around procedures. What we have heard from patients is that it doesn't help to hear a nurse say it's not going to hurt when it is going to hurt. And it also doesn't help to have a nurse kind of rush through the procedure and not even acknowledge a patient's distress around getting their blood drawn or the needles. And so we have implemented some training to have our medical assistants just take a smidgen longer with some of these anxious patients because maybe that's all they need. So really our model is sort of a pyramid model where we're hopeful that 85-90% of patients don't really need any special accommodation. Training the MAs to be a little bit more compassionate will help everyone. And then the remaining 10% who are needle phobic, hopefully some of them will benefit from having a nurse or a medical assistant who's just a little bit more compassionate. If we need to do the numbing cream or the Buzzy Bee, that's available in almost all of our primary care clinics that give vaccines. And then, it's hopefully a smaller, like 1 to 5% who may even need to be referred to the official needle anxiety program and receive even more intervention.
Okay, thank you for that information. So that's all the questions that I have, but I do want to ask you, is there anything that I haven't asked that you think would be important to share with the neurodivergent community or just anything about the program in general?
I would say that, because this protocol has been vetted by so many entities, we had to get approval from ambulatory nursing, from the emergency department, from the anesthesiology department, and then all of our entities that oversee our urgent care. Like this protocol has been looked at by so many eyes. So, I want to say that it's safe and that many people have considered, alternatives to doing this. But in the end, I think ultimately our goal is to not deviate from standard of care for any group of patients. And so, if this intervention is what it needs, is what is needed in order to do that, then I hope that patients will take advantage of it, and that it's safe and that the benefits far outweigh the risk of using an inhaled sedative in order to be able to have their procedure done.
Great, thank you. Well, that's all my questions for you, unless you have anything else to add.
Nope, I think that's about it.
Perfect. Well, thank you so much for taking the time to talk with us about this program.
Okay. Are there any other questions? I mean, from anybody else in the group? What other people might want to know about this program? No?
I think that's it from us.
Okay. Well, let me know. I mean, if you decide that we need to do a video, we'll do it on a non